They wanted to sedate horses. Mission accomplished. Just the wrong species. Hey guys, tonight we're talking about the most horrifying drug crisis America has ever produced. And America has produced some genuinely spectacular ones. Here's a number that should stop you cold. In 2026, more people will die from drug overdoses in Philadelphia than from homicide, car accidents, and diabetes combined. Not separately, combined. One city, one drug, one zip code at the epicenter that has become so infamous that emergency responders sometimes refer to it not by name but simply as the Strip, because everyone knows exactly which strip they mean. Now here's the part that makes this different from every drug story you've heard before. Fentanyl was already killing tens of thousands of Americans a year. It was already the deadliest drug in US history. And then someone decided to mix it with a horse tranquilizer. Not metaphorically, an actual chemical used to sedate large animals before surgery. The result didn't just get people higher, it started eating them alive, literally, from the inside out. People were walking around Kensington Avenue with wounds so deep you could see bone, and they were still injecting into the edges of those wounds because the nerve endings were already dead, and the drug was the only thing that mattered. Dark? Yes. But here's the darkest part. Nobody who built this crisis meant for it to happen this way. It assembled itself piece by piece out of legal prescriptions and insurance cut-offs and cartel economics and political indifference. And by the time anyone with real power looked up, Philadelphia was already gone. Before we continue, subscribe to the channel if you enjoy these stories. Write in the comments where you're watching from and what time it is. I always find it fascinating to see people from around the world united by one story. Philadelphia is a city of neighborhoods. That's how its residents have always described it. Not a monolith, but a mosaic of distinct, stubbornly individual communities packed tightly along the Delaware River. Fishtown has its coffee shops. Rittenhouse Square has its dog walkers and brownstone money. South Philly has its Italian bakeries and its Eagles flags. And Kensington has Kensington Avenue, which by 2026 has become something that resists every ordinary description. Kensington wasn't always this. That matters. It was a working-class manufacturing district, textiles mostly, that employed tens of thousands of people through most of the 20th century. When the mills closed, the jobs didn't relocate to a different neighborhood. They relocated to a different country. What stayed behind was a dense grid of row houses, a population with no economic ladder left to climb, and a pharmaceutical industry that was, at exactly that moment, flooding working-class America with highly addictive painkillers and calling it medicine. The first wave of the opioid crisis hit Kensington like it hit every hollowed-out post-industrial community. Quietly, through legitimate prescriptions, in the form of OxyContin and Percocet handed out by doctors who had been told, and in many cases genuinely believed, that these drugs carried a low addiction risk. Purdue Pharma's sales representatives made that argument with polished presentations and free lunches and a blizzard of misleading research. The FDA approved it. Doctors prescribed it. Patients took it and discovered, after their prescription ran out, that their bodies had been fundamentally rewired. That was the 1990s and 2000s. What happened next followed a logic so grim it almost looks like design. When the federal government finally cracked down on prescription opioids in the early 2000s, restricting supply, reformulating pills to make them harder to abuse, it didn't eliminate demand. It redirected it. People who were physically dependent on prescription pills turned to heroin, which was cheaper, more available, and delivered by a supply chain that had no concern for patient outcomes. Philadelphia's heroin market exploded. And then, just as that crisis was being documented and studied, and the subject of congressional hearings, the supply chain shifted again. fentanyl arrived. Fentanyl is not a new drug. It was synthesized in 1960 and has legitimate medical uses in controlled surgical settings. What made it catastrophic on the street was its potency. It is roughly 100 times stronger than morphine by weight. A lethal dose is measured in micrograms, amounts so small they can't be seen with the naked eye. Mexican cartels, primarily the Sinaloa cartel and the Jalisco New Generation cartel, recognized its economic logic immediately. A kilogram of fentanyl, synthesized from precursor chemicals sourced mostly from China, could produce enough product to replace an entire shipment of heroin at a fraction of the cost and with far greater profit margins. Philadelphia became one of the first American cities to see fentanyl dominate its street supply. By 2016, the majority of opioid overdose deaths in the city involved fentanyl. By 2018, it was nearly all of them. The city deployed Narcan, naloxone, aggressively. Harm reduction workers carried it. Police carried it. Convenience stores stocked it. And it worked, in the narrow sense that people who overdosed on fentanyl alone could often be revived with a dose or two of naloxone. Philadelphia's overdose response infrastructure became, paradoxically, one of the most sophisticated in the country precisely because the crisis forced it to be. And then the supply changed again. Xylazine, pronounced Zwilazine, though most people in Kensington simply call it Tranq, began appearing in Philadelphia's drug supply around 2019. It wasn't a sudden flood. It was a contamination, slow at first, almost invisible in the toxicology data. Medical examiners started noting it on death certificates as a secondary finding, then a primary one. By 2021, xylazine was present in roughly 90% of the fentanyl supply in Philadelphia. That statistic deserves a second read. 9 out of 10 bags of what was being sold as fentanyl in Kensington also contained a large animal sedative that had never been approved for human use, for which there was no antidote, and which caused tissue death in a manner that had never been documented in any human population before. Xylazine is not an opioid. That distinction is not academic. It is the fact that makes everything that follows so much worse. Naloxone works by blocking opioid receptors in the brain, which is why it can reverse a fentanyl overdose almost instantly. Xylazine operates on a completely different system. It's an alpha-2 adrenergic agonist, meaning it works on adrenaline receptors, slowing the central nervous system through a pathway that naloxone cannot touch. When someone overdoses on fentanyl xylazine, Narcan can partially reverse the opioid component, but the xylazine keeps the person sedated, breathing slowly, cardiovascular system suppressed. First responders began encountering a new phenomenon. People who received multiple doses of naloxone, who should have woken up and been aggressively irritable the way fentanyl overdoses usually revived, instead remaining unconscious, grey, unresponsive. But the overdose risk, terrifying as it was, turned out not to be the defining horror of Tranq. The wounds were. Xylazine causes vasoconstriction. It tightens blood vessels, reducing blood flow to peripheral tissue. In a horse, sedated for 20 minutes of surgery, and then woken up in a controlled veterinary environment, this is manageable. In a human being injecting it repeatedly, daily, directly into veins and surrounding tissue, it creates a condition with no parallel in the history of drug use. The tissue stops receiving oxygenated blood. It begins to die. The skin darkens, then blackens. The wound opens. And because xylazine also suppresses pain signals through its sedative mechanism, the person often doesn't feel the wound developing until it is already deep, past the skin, past the subcutaneous fat, into the muscle layer below. By 2026, Philadelphia's emergency rooms had seen wounds that exposed tendons, wounds that reached bone, wounds that had been present for months because the patient never stopped using and the tissue never stopped dying. Infectious disease specialists at Thomas Jefferson University Hospital and Temple University Hospital, the two trauma centres closest to Kensington, began publishing case reports that read less like medical literature and more like dispatches from a war zone. One attending physician described the wounds as something we had no training for because nothing like this had ever existed. The city's response to all of this was complicated. That word is doing significant work in that sentence. Philadelphia had a harm reduction infrastructure, a network of organizations providing clean needles, naloxone, wound care, and connections to treatment. It had a politically progressive DA's office that had cycled through various approaches to drug enforcement. It had two major academic medical centers with dedicated addiction medicine departments. What it did not have, by 2026, was anything close to an adequate response to the specific catastrophe that xylazine represented, because xylazine had outpaced every institutional mechanism built to respond to it. The DEA did not classify xylazine as a controlled substance until 2024, 5 years after it had saturated Philadelphia's drug supply. The FDA issued alerts. Public health officials held press conferences. Grant applications were filed. Meanwhile, on Kensington Avenue, the population of people with active necrotic wounds grew from dozens to hundreds, and the morgue intake forms kept adding a new checkbox. This is where the story begins. Not with a policy failure, though that's part of it. Not with a cartel decision, though that matters too. It begins on a specific street, in a specific city, with a specific person, because statistics are how we count the dead, but they are not how we understand them. Philadelphia in 2026 is ground zero, and ground zero has a population. Marcus Reyes turned 34 in January 2026, though the people who knew him from Kensington would have guessed closer to 50. That gap between what a birth certificate says and what a body shows is one of Tranq's most reliable signatures. It ages people in the way that only prolonged physical destruction can, not gradually, the way years accumulate on a face, but all at once, like a building that stands and then doesn't. He was born in northeast Philadelphia, the part of the city that doesn't appear in documentaries about Kensington. Northeast Philly is row houses and Polish delis and Catholic school uniforms and fathers who work with their hands. Marcus's father was one of them, a pipe fitter who worked union jobs across the Delaware Valley for 30 years and retired with a pension modest enough to disappear in 5. Marcus grew up watching his father come home with torn-up knees and black fingernails, and a particular kind of exhaustion that money softens but never cures. He understood, from an early age, that this was what work looked like: physical, consuming, paid by the hour. He followed the same path without much deliberation. Construction made sense. He was strong. He learned fast. He had his father's tolerance for discomfort and his father's distrust of desk jobs. By his mid-20s, he was doing commercial drywall and framing, working for a mid-sized contractor in Bucks County, pulling decent wages in the years when the Philadelphia suburban construction market was busy enough to keep crews employed through winter. He had an apartment in Frankfurt. He had a daughter named Destiny, born when he was 27, whose mother he wasn't with but shared custody of in the imperfect, functional way that people manage these things when they're both trying. None of this is unusual. That's precisely the point. The back injury happened in the fall of 2018, a standard construction site incident. A load shifted, Marcus twisted wrong trying to stabilize it, and the result was a herniated disc at L4 to L5, the vertebral level that manages to cause maximum misery in anyone who needs to stand, lift, or move for a living. The orthopedic surgeon who saw him was not a villain. He assessed the injury, documented the pain scores, reviewed the imaging, and wrote a prescription for oxycodone because oxycodone was what you prescribed for this kind of acute musculoskeletal pain in 2018, and because the pharmaceutical industry had spent 2 decades making sure that's exactly what doctors believed. Marcus filled the prescription. The pills worked. The disc pain, which had been genuinely disabling, became manageable. He went back to work. What happened inside his brain during those first weeks on oxycodone was not a moral event. It was a chemical one. Opioids bind to receptors in the brain's reward circuitry and trigger a dopamine response of a magnitude that normal human experience almost never produces. The brain, encountering this signal repeatedly, begins to recalibrate. It downregulates its own dopamine production, assuming the external supply will continue. It generates more opioid receptors, increasing sensitivity to the drug. And simultaneously, it begins to experience the absence of the drug not as neutral, as simply the absence of a pleasant feeling, but as physical agony, muscle cramps, bone pain, nausea, anxiety so severe it feels like impending death. This process takes approximately 4 to 8 weeks of regular use. Marcus's initial prescription was for 30 days. When the prescription ran out, his doctor, following updated prescribing guidelines that were being implemented across Pennsylvania in 2018 and 2019, declined to renew it for long-term use. The disc hadn't healed enough for Marcus to consider surgery unnecessary, but it had healed enough that the clinical justification for continued opioid therapy was, on paper, thin. Marcus was told to try physical therapy, NSAIDs, and a referral to a pain management specialist that had a 4-month waiting list. He was already in withdrawal when he left that office. What happens next in Marcus's story happens in thousands of versions across America, and the route is always approximately the same. Someone in his crew knew someone. Pills were available. 30 milligrams of oxycodone, the higher dose formulation, sold individually for prices that climbed as the prescription crackdown tightened supply. Marcus paid because the alternative was unbearable, and because he told himself it was temporary, and because the temporary never ended. Within 6 months, the pills were costing him more than his rent. Within 8 months, someone on a job site mentioned that heroin, actual heroin, did the same thing for a fraction of the cost. He didn't want to be a heroin addict. That framing mattered to him for about 2 weeks. By 2020, Marcus had lost the construction job, not in a dramatic firing, but in the slow erosion of reliability that addiction produces. Showing up late, then not showing up, then showing up wrong. His contractor didn't report him to anyone. He simply stopped getting calls. The apartment in Frankfurt went next, when the security deposit and 2 months' rent became less important than maintaining the supply that his body now interpreted as a survival necessity. Custody of destiny became irregular, then nominal, then something that his ex-girlfriend managed by simply not calling anymore. Each of these losses is a data point in a social worker's intake form. Lived in sequence, they are something closer to drowning, the loss of each handhold making the next one harder to reach. By late 2021, Marcus was in Kensington. The drift toward that neighborhood when someone is unhoused and opioid dependent in Philadelphia is not really a choice. It functions more like gravity. The supply is there. The community of shared survival is there. The informal infrastructure of tents and encampments and people who understand what you're going through is there. Philadelphia's shelter system requires sobriety for many of its beds, which means it functionally excludes the population most in need of housing, depositing them back on streets that lead, always, to Kensington. The transition from heroin to fentanyl happened without Marcus choosing it. The street supply simply changed. By the time he understood that what he was injecting was no longer heroin in any meaningful sense, that it was a synthetic compound orders of magnitude more potent, with a margin between a working dose and a lethal one measured in grains of powder, he was already dependent on it. Fentanyl's shorter duration of action meant withdrawal came faster, craving came harder, and the intervals between injections compressed. Where heroin users might inject 2 or 3 times a day, fentanyl dependents often demanded more frequent dosing just to maintain basic function. Then the bag started changing again. Marcus noticed it before he had words for it. The high felt different, heavier, longer, with a sedation that pressed deeper than fentanyl alone. Some people in the encampment liked it. The extended sedation meant you could get through more of the day without coming back up into withdrawal. Marcus didn't like it, particularly, but he didn't not like it enough to stop, which is the specific calculation that makes Tranq so effective as an addiction mechanism. The first wound appeared on his left forearm in the spring of 2022, a small dark spot slightly sunken at the site of a recent injection. He'd seen similar marks on other people in the encampment and assumed, because this was the assumption available to him, that it was a bruise or a minor infection that would resolve. It didn't resolve. It grew slowly, steadily, with the patient indifference of a process that doesn't need to hurry because nothing is going to stop it. He didn't feel it. That was the part that should have alarmed him, and instead provided a terrible reassurance. If it didn't hurt, it couldn't be that serious. Xylozine's anesthetic effect on damaged tissue removed the warning signal that the human body depends on to register damage. Pain exists to make you stop doing the thing that's hurting you. Tranq wounds exist in a body that has had that mechanism chemically disabled. By the time someone in the encampment, a woman who'd been around long enough to recognize what she was looking at, told Marcus he needed to see a nurse, the wound on his forearm was the size of a silver dollar, and the center of it was black. He was 30 years old. He had been using opioids for less than 4 years. He had a daughter in northeast Philadelphia who knew him as the man who used to take her to the Please Touch Museum and who now existed in her life, mostly as an absence. And he was standing in Kensington in 2022 with a dead patch of tissue on his arm and a drug in his blood that no antidote on earth could reverse. This is not a story about a bad person making bad choices. It is a story about a system so precisely engineered to fail specific kinds of people that the outcomes look, from a distance, like personal failure. Marcus didn't choose the herniated disc. He didn't choose the prescribing practices of 2018. He didn't choose the insurance structure that made ongoing pain management unaffordable and street opioids economically rational. He didn't choose to have a brain that responded to opioids the way most brains do, with dependency so complete it rewrites the hierarchy of needs. What he chose, at each step, was survival. The problem was that the choices available to him were already narrowed to almost nothing by the time he understood the trap he was in, and the trap by 2022 had teeth made of xylazine. The human body is, among other things, a remarkably good problem-solving machine. It seals wounds, fights infection, reroutes blood flow around damaged vessels, and regenerates tissue with an efficiency that no medical technology has fully replicated. It has spent several 100 million years of evolutionary pressure getting very good at keeping itself alive. Xylazine defeats most of that. Not by being exotic, by being precise. Xylazine was developed in 1962 by Bayer, yes, the aspirin company, as a potential human sedative and blood pressure medication. It failed human trials almost immediately. The doses required to produce sedation in people caused cardiovascular depression severe enough to be dangerous, and the compound was shelved for human use. It found its market in veterinary medicine instead, where it became a standard sedative for horses, cattle, and large animals requiring immobilization for medical procedures. In that context, it works beautifully. The animal is sedated, the procedure is completed, the animal is given a reversal agent, it wakes up. Clean, controlled. Veterinarians have used it safely for decades. What Bayer never tested, because there was no reason to, was what happened when a human being injected xylazine repeatedly into compromised veins over weeks and months while simultaneously in a state of chronic malnutrition, immune suppression, and physical stress. The answer, it turned out, was catastrophic. Xylazine's primary mechanism is straightforward. It stimulates alpha-2 adrenergic receptors, which are found throughout the central and peripheral nervous system. Stimulating these receptors produces sedation by reducing the release of norepinephrine, the brain chemical most associated with alertness, arousal, and the fight-or-flight response. Less norepinephrine means slower heart rate, lower blood pressure, reduced breathing rate, and profound sedation. In a horse on a surgical table, this is the goal. In a human being on a sidewalk in January, it means slowed respiration, dangerous cardiovascular suppression, and a sedation so deep that the person cannot be roused by normal stimulation. But the central nervous system effect is almost secondary to what xylazine does in the peripheral vasculature. Blood vessels throughout the body also carry alpha-2 adrenergic receptors, and when xylazine activates them, it causes vasoconstriction, the tightening of blood vessel walls. In large vessels, this raises blood pressure to a degree that can stress the heart. In small vessels and capillaries, the microvasculature that supplies skin and subcutaneous tissue, the constriction is severe enough to drastically reduce or completely cut off blood flow. The tissue downstream of those constricted vessels stops receiving oxygen, stops receiving nutrients, stops receiving the immune cells that would normally fight off bacterial invasion. Tissue without blood supply dies. This is not a metaphor or an approximation. Cells that cannot access oxygen undergo a process called hypoxic cell death within hours, and the dead cells accumulate in a way the body cannot clear because the very blood flow needed for debris removal has been cut off. The result is necrosis, tissue death, that begins at the microscopic level and progresses outward in a radius determined by how extensively the vasoconstriction has cut off supply. In a person injecting fentanyl xylazine directly into a vein, the highest concentrations of xylazine hit the tissue immediately surrounding the injection site. That tissue experiences the most severe vasoconstriction. The skin above the vein darkens as blood flow drops. Subcutaneous fat cells die and liquefy. The wound opens as the dead tissue separates from the living tissue at its edges, a process called demarcation that the body initiates as a last resort to prevent spreading infection. And then the wound simply stays open, because the same vasoconstriction that caused it continues with every subsequent injection, and the body's wound-healing mechanisms, which require blood flow to deliver collagen-producing cells, cannot operate. What makes this uniquely horrifying is the location. Tranq wounds do not only appear at injection sites. This was one of the first things that baffled clinicians when they began seeing tranq wounds in volume. Patients presented with necrotic lesions on parts of the body where they insisted they had never injected: the chest, the legs, the face. The explanation, once understood, was chilling in its simplicity. Xylazine, once injected into the bloodstream, circulates systemically. The vasoconstriction it causes is not limited to the injection site. It affects microvasculature throughout the body. In areas where tissue is already compromised, where there's pressure from clothing, minor unnoticed abrasions, or underlying inflammation, the reduced blood flow tips the balance from marginal survival to cell death. Wounds appeared seemingly spontaneously, in locations that made no anatomical sense until you understood that the drug was shutting down blood supply body-wide. Marcus had 3 wounds by the spring of 2023, one on his left forearm, one on his right inner elbow, one on his left shin, where the skin had broken down under the edge of his pants during a period when he'd slept outdoors in wet weather. He had not injected into his shin. The wound didn't care. The bacterial dimension made everything worse by an order of magnitude. Open necrotic wounds in a person who is unhoused, injecting shared equipment, and unable to maintain consistent hygiene are ideal environments for bacterial colonization. The organisms that took up residence in Tranq wounds were not ordinary skin bacteria. Medical teams documented polymicrobial infections involving Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, MRSA, and anaerobic bacteria more typically associated with soil contamination and penetrating trauma injuries. These are hospital-grade pathogens, organisms that challenge infectious disease specialists even in controlled ICU settings with full antibiotic arsenals available. On Kensington Avenue they were being managed with stolen gauze and bottled water. The pain situation deserves particular attention because it is both a mercy and a trap. Tranq wounds in active xylazine users are frequently described as painless or minimally painful, not because the tissue damage is mild, but because xylazine's anesthetic properties suppress the pain signals that the wound would otherwise generate. The nerve endings in and around the necrotic tissue are themselves affected by the drug's vasoconstriction and its direct anesthetic action. A person with a wound exposing muscle tissue might describe it as a pressure or tightness rather than pain, and might genuinely not understand why a nurse is looking at them with undisguised alarm. This creates a clinical nightmare. Pain is the mechanism that drives people to seek care. Remove pain, and you remove the urgency signal. People with Tranq wounds that should have prompted emergency hospitalization weeks earlier instead arrived at clinics or ERs at the point when the wound had progressed to sepsis, when the infection had breached the wound's boundaries and entered the bloodstream. Sepsis from Tranq wounds carried a mortality rate that infectious disease physicians described in their case reports using language rarely found in academic literature. One study from Jefferson Hospital described the wound burden in their Tranq patient population as unlike anything previously encountered in civilian medicine. The naloxone problem compounded every other problem. When a bystander encounters someone unconscious on a Philadelphia sidewalk in 2026, the reflex action, the action drilled into harm reduction workers, passers-by, and first responders by years of public health campaigns, is to administer naloxone, Narcan, the opioid antidote, and naloxone does work on the fentanyl component of a Tranq overdose. It displaces fentanyl from the opioid receptors and begins reversing the opioid-driven respiratory depression. But the xylazine-driven sedation continues. The person may begin breathing more regularly as the fentanyl effect is reversed, but they remain deeply sedated, blood pressure suppressed, unresponsive to stimulation. First responders across Philadelphia began reporting a new and disturbing pattern. Multiple naloxone doses administered, partial response, patient technically alive but not conscious, no further improvement. The standard protocol, administer Narcan, patient wakes up agitated, patient refuses transport, patient walks away, no longer applied. Tranq overdoses require prolonged supportive care, positioning to protect the airway, monitoring of cardiovascular function, time for the xylazine to metabolize out of the system naturally. In a hospital, this is manageable. On a sidewalk, waiting for an ambulance in a neighborhood where response times have been stretched thin by call volume, it was a window during which people died. There is no antidote for xylazine. That sentence stated plainly, is one of the most significant facts in contemporary American public health. Naloxone reversed the opioid crisis's primary killing mechanism with a molecule that cost a few dollars and could be administered by anyone with 30 seconds of training. Xylazine provided no such lever. The FDA began expedited review of potential reversal agents in 2023, and by 2026 several compounds were in clinical trials, but nothing had cleared the bar for emergency use authorization. Every xylazine overdose that happened in Philadelphia in early 2026 was treated with supportive care and hope. The body, for its part, kept trying. White blood cells flooded wound sites in numbers that produced the angry red inflammation visible at wound margins. The immune system attempted to wall off infections with abscess formation. Skin at wound edges tried to migrate inward, a process called epithelialization, only to find the underlying tissue too compromised to support new growth. The body's repair mechanisms were not absent. They were overwhelmed and systematically undermined by the continued presence of a compound that cut off the blood supply those mechanisms depended on. Every injection reset the clock. As long as xylazine remained in the system, and with daily injection, it always remained in the system. The vasoconstriction never fully resolved, the wound never fully closed, and the tissue at the margins continued its slow progression toward necrosis. Clinicians who worked with Tranq patients described the wound trajectory in terms that sounded less like medicine and more like physics, an irreversible process, gaining momentum, indifferent to intervention as long as the underlying cause persisted. The underlying cause persisted because stopping it required surviving withdrawal from a fentanyl-xylazine combination that produced a withdrawal syndrome more severe, more prolonged, and more resistant to standard medication-assisted treatment than opioid withdrawal alone. Xylazine withdrawal, understudied, underdocumented, encountered clinically only as the crisis scaled, produced symptoms that mimicked the worst of opioid withdrawal while adding its own contribution. Severe agitation, autonomic instability, a physical and psychological torment that people who had survived both described as worse than anything fentanyl withdrawal produced alone. Marcus, in 2023, knew none of the pharmacology. He knew that the spot on his arm was getting bigger. He knew that when he didn't use, the world became unbearable within hours. He knew that when he did use, the spot didn't hurt. And he knew, with the particular clarity that people in impossible situations sometimes achieve, that he was in serious trouble, and that the thing keeping him alive was also killing him. He just didn't know how to make it stop. Kensington Avenue runs roughly north to south through a neighbourhood that looks, from a satellite image, like any other dense urban grid. Row houses packed tight, corner stores, an elevated rail line casting iron shadows across the street, churches, a dollar store, a check cashing place. The satellite image doesn't show you what's on the sidewalk or in the doorways or under the overpass at Gurney Street where the shadow is permanent and the ground is covered in a sediment of used syringes, discarded packaging, and the accumulated debris of people who have nowhere else to be. By 2026, the strip of Kensington Avenue between Allegheny and Lehigh had been the subject of more documentary films, news segments, academic papers, and political speeches than almost any comparable block in American urban history. Journalists came from Europe, from Japan, from Australia, to photograph and film and report. Philadelphia residents from other neighborhoods drove past slowly and filmed through car windows. The people on the sidewalk had become, without consenting to it, the most documented population of drug users on the planet. And the documentation changed nothing about the supply, or the withdrawal, or the wounds. What the cameras rarely captured, because it happened in side streets and abandoned buildings, and in the practiced invisibility of people who had learned to exist in plain sight, was the actual functioning of the ecosystem that Kensington had become. It had a hierarchy, Not formal, not organised in any way that would be legible to someone expecting gang structures or criminal enterprise, but real nonetheless. At the top of the immediate street economy sat the corner dealers, young men, mostly, working for supply networks that connected back through layers of distribution to the cartels that manufactured the product in Sinaloa and Jalisco. These were not the kingpins of movie mythology. They were employees, paid in product and small cash, carrying enough supply to maintain street-level sales and enough risk to absorb a significant portion of law enforcement attention. They were replaceable. Everyone in the chain knew they were replaceable. Below them, in economic terms, was the horizontal economy of the users themselves, an elaborate informal market in which services, objects and information had recognized value. Someone who knew which pharmacy restocked Narcan on Tuesdays, someone who could score clean syringes, someone who understood wound care well enough to change a dressing without causing additional damage. These skills were currency. The economy operated on a barter logic that was, in its own terrible way, highly functional, The abandoned row houses, Philadelphia has thousands of them, scattered across the city but concentrated in its poorest neighborhoods, served as the critical infrastructure. What outsiders called shooting galleries, the people who used them called, simply, inside. Inside meant out of the wind. Inside meant away from police. Inside meant somewhere to be horizontal when the xylazine sedation hit, and standing upright became impossible. The city periodically boarded these buildings. Boards were removed within days. The structural logic was unchanged. The buildings were empty, the people needed to be somewhere, and no available alternative existed. In these spaces, something happened that defied the dominant cultural narrative about drug addiction as a condition of radical isolation. People watched out for each other. Not always, not reliably, not in ways that overcame the fundamental brutality of the situation, but genuinely. Someone noticed when a person they recognized hadn't moved in too long. Someone administered Narcan from a kit they'd gotten at Prevention Point. Someone changed a dressing on a wound because leaving it unchanged was a death sentence operating on a slower clock than overdose but equally certain. The harm reduction workers who entered these spaces daily understood this social fabric better than anyone. Prevention. Point Philadelphia, one of the oldest needle exchange programs in the country, founded in 1991, operated out of a van and a fixed site, distributing clean supplies, naloxone, wound care kits, and connection to services. By 2026, their wound care caseload had grown to a scale that their funding had never anticipated. Nurses documented cases in a population that was largely invisible to the formal healthcare system. People who hadn't seen a primary care doctor in years, whose only medical contact was through harm reduction workers in parking lots and encampments. Those nurses saw things that would have been extraordinary in any other context. Wounds that had been present for 6 months. Wounds treated with whatever was available. Menstrual pads as absorbent dressings, duct tape to hold bandages, antibiotic ointment applied to tissue that was already past the point where topical treatment could help. The improvised wound care was not ignorance. It was resourcefulness operating at the absolute limit of available materials. People understood their wounds were serious. They lacked the means to treat them adequately and the ability, given their dependence, to stop the process causing them. The city's response to all of this had, by 2026, settled into a rhythm of managed futility. Police sweeps happened on a schedule that the Kensington population had largely internalized. Officers would arrive, tents would be cleared, belongings would be confiscated or destroyed, and the population would disperse to side streets, to neighbouring blocks, to the stretch of Lehigh Avenue that was technically outside the sweep zone. Within days, sometimes within hours, the population reconcentrated. The encampments reformed with the efficiency of a system that had done this many times before. A 2025 study from Drexel University's Dornsife School of Public Health documented that every major police sweep of Kensington between 2020 and 2025 had been followed by a measurable spike in overdose deaths, not because the drugs disappeared, but because the social networks that supported survival had been temporarily fractured. People who had been monitoring each other couldn't find each other. Narcan was with someone who was now 3 blocks away. The informal wound care network was disrupted. The sweeps didn't reduce drug use, they redistributed risk. By 2026, the drug supply itself had undergone another evolution that the street population was still adapting to. The deliberate addition of xylazine to fentanyl by cartel supply networks, first documented by DEA chemists in 2022, had by this point become so systematic that obtaining fentanyl without xylazine in Philadelphia was genuinely difficult. The cartels had discovered xylazine's market value not through any particular malice toward users, but through straightforward product economics. Xylazine extended the duration of the high, meaning users experienced a longer period of sedation per dose. It also dramatically accelerated physical dependence. The cycle of needing the drug to avoid withdrawal tightened. And because xylazine was technically not a controlled substance until 2024, its legal status had provided a brief window of easier procurement that the supply chain exploited thoroughly before the DEA classification closed it. The new formulations circulating in the early 2026 were, by toxicology reports and harm reduction worker field observations, more xylazine-heavy than anything previously documented. Street tests, fentanyl test strips had been widely adopted, but xylazine test strips were newer and less available, confirmed concentrations that were producing faster, deeper sedation and more aggressive wound development in new users. People who had been using for 6 months were presenting with wounds that 2 years earlier had taken 18 months to develop. The acceleration was not accidental. It was, from a certain perspective, a feature. Marcus understood the market dynamics in the way that anyone understands the rules of the environment they're surviving in, not through analysis, but through accumulated experience. He knew which corners had hotter product. He knew which batches had produced overdoses in the encampment and which hadn't. He knew the rhythm of supply, when it was thin, when it was strong, when something new had entered the mix. This knowledge was not trivial. It was, in the most literal sense, survival information. What he couldn't navigate was the medical reality accumulating on his arm. The wound care system that harm reduction workers tried to maintain for Marcus, and for the hundreds of people like him on the strip, operated under constraints that made adequate care nearly impossible. Wound care requires clean supplies, sterile gauze, antiseptic solution, appropriate dressings, and ideally assessment by someone with clinical training. Prevention Point's nurses provided this when they could reach their clients, and when their clients could be reached. But wound care also requires consistency. The same wound needs to be assessed at regular intervals, cleaned, redressed, and monitored for signs of infection progression. Consistency is the thing that homelessness, addiction, and an under-resourced harm reduction system most reliably cannot provide. Marcus's wound was cleaned perhaps twice a week when circumstances allowed. Between those visits, it was covered with whatever was available, in whatever conditions the abandoned row house provided, by hands that were not always clean and supplies that were not always sterile. The bacteria did not take days off. The xylazine didn't reduce its concentration out of consideration for healing. The wound grew because the conditions that produced it never paused. The human stories layered inside this ecosystem were too numerous and too varied to reduce to a single narrative. There was the 19-year-old from Bucks County who'd come to Kensington 2 months ago, and was still surprised by almost everything. The 55-year-old woman who had lived on this strip for 12 years and who knew more about wound care, overdose response, and navigating the harm reduction system than most medical students. The man who stood at the corner of Kensington and Allegheny every morning at the same time, performing a census in his head of who was there and who wasn't, because someone had to know. All of them existed inside a system that had decided through budget allocations and policy choices and public indifference that this level of suffering was an acceptable operating cost of an approach to drug policy that had failed for 50 years. The war on drugs had not ended. It had simply evolved into something that looked less like enforcement and more like containment, and Kensington was the container. Marcus was in it, and the container was getting smaller. The prevention point nurse who first properly documented Marcus's left forearm wound was named in her clinical notes only by her staff ID, a anonymization protocol the organization used to protect both workers and clients. Her notes, dated March 2023, described a wound approximately 4 centimeters in diameter at the mid-forearm, with necrotic tissue at the center, erythematous margins indicating active infection, and early signs of undermining. The clinical term for when a wound's destruction extends laterally beneath apparently intact skin, hollowing it from below like rot inside a wall. She cleaned it, dressed it, photographed it for the wound tracking database prevention point had developed specifically for the Tranq crisis, and scheduled Marcus for a follow-up in 4 days. He came back in 6. The wound had grown by roughly 1 centimeter in every direction. The undermining was more extensive. A smell had developed, faint but distinct. The particular sweetness of anaerobic bacterial activity in tissue that is no longer receiving sufficient oxygen to support normal cellular respiration. To anyone with clinical wound care experience, that smell has a specific meaning. The infection has gone deeper than the surface presentation suggests, and the clock is running faster than the visible evidence indicates. The nurse referred Marcus to the prevention point medical van for physician assessment. He went, which was not nothing. Many people at his stage of wound progression refused further engagement, partly from distrust, partly from the particular cognitive fog that chronic xylazine exposure produced, and partly from a rational calculation that more assessment meant more pressure to enter treatment, and entering treatment meant withdrawal, and withdrawal meant something they were not yet prepared to survive. The physician who assessed him was a volunteer, an infectious disease specialist from Penn Medicine who gave 2 half-days a month to the van. She'd been doing this for 3 years and had watched the wound burden in the Kensington population transform from a manageable clinical problem to something that exceeded her capacity for clinical detachment. She documented Marcus's wound, cultured the discharge, prescribed a course of oral antibiotics, trimethoprim sulfamethoxazole, chosen because it covered the MRSA she suspected, and because oral medication was the only realistic option for someone without stable housing, and told him, in the careful language of someone who has learned to calibrate urgency to what a patient can actually hear, that the wound needed hospital-level care. Marcus took the antibiotics for 4 days. Then he ran out, or lost them, or traded them. The record doesn't specify. The bacteria did not take a 4-day course of antibiotics as a surrender. By July 2023, the wound had expanded to 7 centimeters at its widest point. The necrotic center had deepened past the subcutaneous fat layer and into the fascia, the dense connective tissue sheath that wraps muscle groups. This depth of involvement had a clinical name, deep tissue necrosis, and it carried implications that surface wounds did not. Fascia has poor blood supply under normal circumstances. Once necrotic, it does not regenerate. And bacteria that reach the fascial plane have access to a highway of connective tissue that runs continuously up the arm, providing a route for infection to spread toward the elbow, the shoulder, the chest wall, and eventually the systemic circulation. The bacteria found the highway. They always find the highway. It was a harm reduction outreach worker, not a nurse, just a person who walked the strip daily with supplies and a phone and a genuine understanding of who was who finally got Marcus into a van and drove him to Temple University Hospital's emergency department in August 2023. Not because Marcus had decided he was ready, because he had been found semi-conscious in the doorway of an abandoned row house on Tusculum Street, wound, visibly infected, running a fever that the outreach worker estimated, correctly it turned out, at somewhere above 103 degrees. The emergency department at Temple University Hospital in North Philadelphia is one of the busiest trauma centers in Pennsylvania. Its staff had been managing tranq wound cases in increasing volume since 2021, and by 2023 had developed protocols specifically for this patient population. Marcus was triaged, blood cultures were drawn, IV antibiotics were started within the hour. The wound was formally assessed by the surgical team. 8 centimeters long, 5 centimeters wide, depth reaching the muscle layer, with fascial involvement and signs of early osteomyelitis, bone infection at the ulna, the forearm bone running along the inner arm. Osteomyelitis changed the calculation entirely. Bone infection is among the most difficult bacterial infections to treat because bone tissue has limited blood supply, making it hard for antibiotics to reach the infected site at therapeutic concentrations. Standard treatment requires 6 weeks of intravenous antibiotics, administered in a hospital or through a peripherally inserted central catheter, a PICC line, that allows IV administration in an outpatient setting. The surgical team also noted that the infected bone would likely require debridement, the surgical removal of dead bone tissue, to give the antibiotic therapy any chance of working. Marcus was admitted. For the first 18 hours he cooperated with everything. The hospital social worker who met with him on the second morning documented a man who was coherent, frightened, and, critically, in the early stages of withdrawal. Fentanyl xylazine withdrawal in a hospital setting is a specific kind of purgatory. The opioid component produces the classic withdrawal syndrome: muscle cramps severe enough to cause visible writhing, gastrointestinal distress, sweating, insomnia, a psychological agony that people who have experienced it consistently describe as the worst suffering of their lives. The xylazine component adds its own layer: heightened agitation, cardiovascular instability, a rebound hypertension, as the alpha-2 suppression lifts that can produce dangerous spikes in blood pressure. The hospital had buprenorphine, the medication that partially manages opioid withdrawal by occupying opioid receptors, and they administered it. It helped with the opioid withdrawal. The xylazine component remained largely unaddressed, because no established pharmacological protocol for xylazine withdrawal existed in 2023, and the physicians were managing it empirically, trying combinations of clonidine and benzodiazepines that reduced the cardiovascular instability without fully resolving the agitation. Marcus spent 36 hours in a state that the nursing notes described as extremely distressed. That is clinical language for something that looked to anyone present like a person being unmade from the inside. The social worker presented him with options: a residential detox bed in a facility in West Philadelphia, available in approximately 9 days, a referral to an outpatient medication-assisted treatment program that had a 3-week intake backlog, continued hospitalization for wound and bone infection treatment, with EMAT initiated in hospital. The social worker was good at her job, experienced with this population, and realistic about the probabilities. She documented the conversation carefully. On the morning of the 3rd day, Marcus left against medical advice. The AMA, against medical advice, Departure is one of the most studied and most misunderstood phenomena in addiction medicine. To hospital administrators and insurance systems, it registers as a failed admission, resources expended, outcome not achieved, patient non-compliant. To clinicians who work with this population daily, it is something more complicated. A person in withdrawal, in a foreign environment, separated from the drug their body is screaming for, surrounded by people they have learned through years of experience not to fully trust. That person leaving is not behaving irrationally. They are responding to a set of incentives and terrors that are, from inside the experience, completely logical. The street had Marcus's drug. The hospital had a 9-day wait for a detox bed and a wound that was going to require 6 weeks of IV antibiotics and probable surgery. The street's offer was immediate. The hospital's offer required surviving something that felt, physiologically, unsurvivable. He signed the AMA form with his right hand because his left forearm was bandaged from wrist to elbow. Back on Kensington Avenue, within hours of discharge, Marcus injected. The withdrawal stopped. The relief was total and immediate, the way only the specific thing your body is demanding can be. The bandages the hospital had applied began to soak through within 2 days, not from wound drainage alone, but because he was injecting as close to the wound as accessible tissue allowed, and the trauma of repeated injection into already damaged tissue accelerated the breakdown. The bone infection continued its work without interruption. Osteomyelitis, untreated with adequate antibiotics, doesn't pause while the patient reconsiders. It spreads through bone tissue at its own pace, destroying structural integrity, seeding bacteria into the bloodstream in periodic pulses that can lodge in distant organs, heart valves, spine, brain, with consequences that arrive without warning and often without survivable treatment options. Marcus's left arm was, by September 2023, past the point where antibiotics alone could reverse the damage. The wound had become something that medical literature categorizes with clinical precision, and that the human eye categorizes as simply wrong, an opening in a living person's body through which the internal architecture of the arm was directly visible, pink and white and glistening, the muscle fibers tracking across the base of the wound like cables, the bone surface visible at the deepest point, its normal ivory colour replaced by the dull grey-yellow of infected cortical bone. He was still injecting into the margins of it. Not because he didn't understand it was serious, because the nerve endings at the wound margins were dead, and the accessible veins elsewhere in his arm had collapsed from years of use, and the drug was the only currency his body accepted for staying functional. The wound had been there for over a year. It had never, not once, shown a single sign of healing. And Marcus wasn't the only one. Prevention Point's wound database by the end of 2023 documented 340 active Tranq wound cases in their caseload, and they estimated this represented perhaps 30% of the actual wound burden on Kensington Avenue. The cases they weren't seeing, the people who hadn't been reached by outreach workers, who refused contact, who were deeper into the abandoned buildings. Those were the cases that would eventually arrive at Temple and Jefferson as emergency surgical admissions, septic, hemodynamically unstable, sometimes too far gone for the intervention that might have saved them weeks or months earlier. Marcus's second hospital admission was coming. Everyone in the system who knew his case could see it approaching with the slow inevitability of a wound that had been growing, uninterrupted, for 18 months. The only question was whether he'd arrive conscious. Marcus's story did not begin with a bad decision. It began with a bad system, and that system had been failing, methodically, expensively, with considerable documentation, for decades before Marcus ever filled his first opioid prescription. Understanding how requires going back further than most drug crisis narratives bother to go. Pennsylvania's mental health and addiction treatment infrastructure was systematically dismantled across the 1990s and 2000s through a series of budget decisions that were individually defensible and collectively catastrophic. State psychiatric hospital beds were cut by more than 60% between 1990 and 2010, driven by a combination of legitimate concerns about institutionalization and thoroughly illegitimate assumptions about what community-based alternatives would materialize to replace them. The community-based alternatives were funded at roughly a third of the level required to serve the displaced population. The gap between the beds eliminated and the services created was filled by emergency rooms, jails, and eventually streets. This was not unique to Pennsylvania, but Pennsylvania had an additional problem. It was Purdue Pharma's most aggressively targeted state. Internal Purdue documents, released through litigation and eventually through the company's 2020 bankruptcy proceedings, revealed that Pennsylvania physicians were among the highest volume OxyContin prescribers in the country. The company's sales force had identified the state's working-class industrial corridor, exactly the demographic Marcus came from, as a priority market. Sales representatives visited physicians in Northeast Philadelphia, Bucks County, and the Philadelphia suburbs at frequencies that bore no relationship to clinical need and every relationship to market penetration strategy. Prescribing rates in working-class zip codes correlated directly with subsequent addiction and overdose rates, a relationship so consistent that epidemiologists described it as dose-dependent. More pills prescribed, more addiction produced, more overdoses followed. Philadelphia's Department of Public Health watched the overdose data climb through the 2000s and 10s and did what public health departments do. They documented it, published reports, held summits, applied for federal grants, and waited for political will to translate into resources. The political will was inconsistent at best. Pennsylvania's state legislature, dominated for most of this period by representatives from suburban and rural districts, with complicated relationships to both drug policy reform and the pharmaceutical industry, allocated addiction treatment funding at levels that public health officials described in testimony as catastrophically inadequate relative to the documented need. The Medicaid situation was its own special category of failure. Pennsylvania expanded Medicaid under the Affordable Care Act in 2015, later than most states, after years of political resistance, and the expansion theoretically provided addiction treatment coverage to hundreds of thousands of previously uninsured Pennsylvanians. In practice, the gap between coverage and actual access to care was a chasm. Medication-assisted treatment providers, the physicians and clinics authorized to prescribe buprenorphine and methadone, were distributed across the state in a pattern that had everything to do with where providers chose to practice and nothing to do with where need was concentrated. In Kensington, the ratio of people needing EMAT to providers available to deliver it was, by 2022 estimates, approximately 40-1. 40 people competing for every available treatment slot, in a condition where waiting lists measured in weeks meant withdrawal measured in days, and withdrawal in days meant return to the street in hours. The federal response to xylazine specifically illustrated every pathology of the regulatory system simultaneously. Xylazine was first flagged as a public health concern in Puerto Rico in the early 2000s, where it had entered the drug supply nearly 2 decades before it reached Philadelphia. Puerto Rican public health officials documented the wounds, the overdoses, the treatment complications, and published their findings in medical journals that circulated within infectious disease and addiction medicine communities. The DEA reviewed the data and determined that xylazine did not meet the criteria for scheduling under the Controlled Substances Act, primarily because it was not being used recreationally for its own effects, but as an adulterant in other drugs. This was technically accurate and practically irrelevant. The compound was destroying people regardless of its scheduling status. When xylazine began appearing in Philadelphia's drug supply around 2019, the DEA's existing determination meant there was no federal legal mechanism to immediately restrict its distribution. It was sold legally as a veterinary product. Anyone could purchase it. Cartel distributors could add it to fentanyl without triggering any additional controlled substance violation. The DEA began a new scheduling review in 2021. The process took 3 years. By the time xylazine was classified as a Schedule III controlled substance in 2024, it had been saturating Philadelphia's drug supply for 5 years and had killed or permanently maimed thousands of people. The FDA's response followed a similar timeline of insufficient urgency. The agency issued a public health alert about xylazine in fentanyl in April 2023, 4 years after the compound began appearing in toxicology reports at significant rates. The alert recommended that clinicians be aware of xylazine's presence and its implications for overdose response. It did not establish treatment protocols. It did not authorize emergency use of any reversal agent. It did not allocate emergency funding for wound care infrastructure. It was, in the precise language of bureaucratic acknowledgement, an awareness-raising measure. The awareness, among people living on Kensington Avenue, was already quite high. Philadelphia's own political response to the crisis oscillated between approaches in a way that managed to capture the worst aspects of each without the benefits of any. The DA's office under Larry Krasner, elected in 2017 on a reform platform, deprioritized low-level drug possession prosecutions, which reduced the number of people cycling through the criminal justice system for personal use, and was, from a public health standpoint, clearly the right call. But reduced prosecution without expanded treatment infrastructure simply meant that people were using without legal consequence in an environment that still had no adequate clinical support. The reform created space that the treatment system lacked the resources to fill. The supervised consumption site, a facility where people could use pre-obtained drugs under medical supervision with immediate overdose response available, had been debated in Philadelphia since 2018. The evidence base for such facilities was robust. Vancouver's Insight, opened in 2003, had overseen more than 3.6 million injections without a single on-site overdose death. Studies across multiple countries consistently showed that supervised consumption sites reduced overdose mortality, increased uptake of treatment, and decreased public drug use without increasing drug use rates in surrounding communities. Philadelphia's proposal was blocked by federal law. The Controlled Substances Act's crack house statute, which prohibited maintaining premises for drug use, and by a political environment in which supporting such a facility carried electoral risk that few politicians were willing to absorb. Meanwhile, people were dying in doorways 3 miles from City Hall. The harm reduction organizations that operated in the gap between what the system provided and what the population needed were, by 2026, running on a combination of grants, donations, and the particular human stubbornness that develops in people who have watched preventable deaths accumulate for years. Prevention Point's annual budget was approximately $4 million for an organization serving thousands of people with some of the most complex medical and social needs in the city. The Philadelphia Department of Public Health's entire harm reduction services budget was less than the cost of 2 weeks of police overtime during a single Kensington sweep operation. The numbers are not metaphors, they are choices rendered as arithmetic. Next Distro, a male-based harm reduction supply organization that had expanded its Philadelphia operations as the Tranq crisis scaled, documented in its 2025 annual report that demand for wound care supplies had increased 340% since 2021. Sterile gauze, wound irrigation syringes, antiseptic solution, materials that cost pennies per unit in bulk hospital procurement, were being rationed in the field because the budget to purchase them in adequate quantities didn't exist. Nurses were making clinical decisions about which wounds to prioritise based not on medical acuity, but on supply inventory. The research community was at least paying attention. A consortium of Philadelphia academic institutions, Penn, Jefferson, Temple, Drexel, had produced more peer-reviewed literature on the Tranq crisis by 2025 than on any comparable drug phenomenon in the city's history. The research documented everything: wound epidemiology, treatment outcomes, social determinants, cost-effectiveness of intervention models. It was thorough, rigorous, and largely unread by the legislators who controlled the funding required to act on it. There is a particular kind of institutional failure that doesn't look like failure from the inside. Everyone is filing the right reports, the meetings are being held, the task forces are meeting, the data is being collected. From inside any individual agency, the work looks like work. Only from a distance, from the perspective of someone counting the bodies, or the wounds, or the people cycling through the same emergency rooms every few months, does the aggregate picture resolve into something that looks less like a response and more like an elaborate performance of response. Marcus had never read a policy report. He had never attended a city council meeting about harm reduction funding. He had no particular opinion about the DEA's scheduling timeline or the FDA's alert mechanisms. What he had was a wound on his arm that had been growing for 18 months, a drug his body could no longer function without, and a system that had been designed, through decades of choices, large and small, made by people who would never see the consequences, to be exactly inadequate enough to ensure that people like him fell through every available gap. The gap between what Marcus needed and what existed to provide it was not an accident. It was a policy outcome, and in 2024, that outcome was about to become surgical. Tuesday morning, February 4th, 2025. The temperature on Kensington Avenue was 11 degrees Fahrenheit, which is the kind of cold that doesn't negotiate. It penetrates layered clothing, it stiffens fingers, it turns concrete into something that pulls heat from a sleeping body with quiet efficiency. The overnight population in the encampment under the Gurney Street overpass had compressed together for warmth, which meant that when Marcus went still sometime before dawn, several people were close enough to notice. Close enough. Not close enough to notice immediately. The person who called 911 was a woman who'd been awake since 3 a.m. with withdrawal cramps severe enough to make sleep impossible. She'd been watching Marcus for approximately 20 minutes before she made the call, not out of indifference, but because calling 911 to Kensington triggered a specific cascade of consequences that the community had learned to weigh carefully. Police came with paramedics. Police presence meant potential arrest, meant belongings searched, meant the fragile social structure of the encampment disrupted. 20 minutes of watching a man's chest move almost imperceptibly, running the calculation of whether to call. She called. Philadelphia Fire Department paramedics arrived in 8 minutes, a response time that, given the call volume in that district, represented a system operating at capacity rather than failure. They found Marcus supine on a piece of corrugated cardboard, unconscious, breathing at a rate of 4 breaths per minute. 4. The normal range is 12 to 20. At 4 breaths per minute, carbon dioxide accumulates in the blood faster than the lungs can clear it. The blood becomes acidic, and the cascade of metabolic dysfunction that ends in cardiac arrest runs on a timeline measured in minutes rather than hours. The first paramedic administered naloxone intranasally, the fastest delivery route in a field setting, while his partner established a bag valve mask ventilation to mechanically support Marcus's breathing. The naloxone dose was 4 milligrams, standard protocol for suspected fentanyl overdose. Within 90 seconds, Marcus's breathing rate climbed from 4 to 8 breaths per minute. The fentanyl component was being reversed. He did not wake up. The second paramedic administered another 4 milligrams of naloxone. Breathing improved marginally, 10 breaths per minute now, borderline adequate. But Marcus remained completely unresponsive, eyes fixed, muscle tone absent, blood pressure dangerously low. 8 milligrams of naloxone in a fentanyl-only overdose would have produced a patient who was awake, agitated and arguing about going to the hospital within 3 minutes. 8 milligrams produced a man who was breathing slightly better, but otherwise showed no signs of returning consciousness. Both paramedics understood exactly what this meant. They had seen it dozens of times. The xylazine was running its own program, entirely indifferent to the naloxone flooding Marcus's system. His alpha-2 receptors were saturated. His cardiovascular system was suppressed along a pathway that no available drug in the paramedic's kit could reverse. The sedation would lift only when his liver metabolized the xylazine out of his system, a process that, depending on the dose and the individual's metabolic rate, took anywhere from 2 to 6 hours. Marcus was loaded into the ambulance with an IV established, supplemental oxygen running, and cardiac monitoring attached showing a heart rate of 42 beats per minute, bradycardic, slow but regular. The ambulance moved toward Temple University Hospital with lights and sirens running, not because there was anything more that speed could add to the treatment, but because the monitoring showed a rhythm that could deteriorate without warning, and the hospital had equipment the ambulance did not. He arrived in the Temple ED at 7:23 a.m. The emergency physician who received him had managed more Tranq overdoses than she could individually remember. They had blurred, over the years, into a composite clinical picture that her hands and instincts responded to automatically. IV access checked, fluids running, repeat vital signs, blood glucose, low, consistent with someone who hadn't eaten adequately in days, warming blankets for the hypothermia, blood cultures drawn to assess for sepsis given the known wound burden on his arm, chest X-ray to rule out aspiration pneumonia, which occurred commonly in unconscious patients who had been lying on their backs. The chest X-ray showed a small infiltrate in the right lower lobe, aspiration pneumonia. One more item on the list. By 10 a.m., Marcus was in a monitored bed in the emergency department, his xylazine levels falling as his liver processed the dose, his consciousness returning in the gradual disoriented way that xylazine sedation lifts, not the sharp, argumentative awakening of naloxone-reversed fentanyl overdose, but a slow surfacing through layers of confusion, the way someone emerges from general anesthesia. He knew where he was before he could articulate it. He knew what had happened before he was ready to discuss it. The attending physician documented his wound during the exam and immediately escalated. What had been, at the time of his first admission 18 months earlier, a severe but potentially manageable wound was now something categorically different. The necrotic area had expanded to involve the majority of the forearm's dorsal surface. The bone infection, untreated since his AMA departure, had progressed extensively. The wound edges showed signs of active cellulitis, spreading bacterial infection into surrounding healthy tissue, and the lymph nodes in his axilla, the armpit above the affected arm, were visibly swollen and tender, indicating that the infection had already begun moving through the lymphatic system towards systemic circulation. An orthopedic surgery consult was called. An infectious disease consult was called. A social work consult was called. The machinery of a teaching hospital's response to a complex case engaged with an efficiency that was, under the circumstances, both impressive and insufficient. The infectious disease attending reviewed the wound, the previous culture results from the 2023 admission and the current blood cultures, and delivered an assessment to the team that the nursing notes captured in spare clinical language. Extensive polymicrobial osteomyelitis, probable bacteremia, wound not salvageable with antibiotic therapy alone, surgical intervention required urgently. The orthopedic surgeon examined the arm and agreed. The question of what surgical intervention meant, debridement, partial resection, or something more radical, was left for a formal surgical planning discussion, but the direction was clear to everyone in the room. Marcus, emerging from sedation into a world that included this information, was also emerging into the early stages of withdrawal. The dual reality of understanding that his arm needed surgery while his body was beginning to demand the drug that had caused the problem. This collision produced a psychological state that the nursing notes, with their careful clinical neutrality, described as highly anxious and ambivalent. The social worker who'd been assigned to his case was different from the one he'd seen in 2023. Staff turnover in this department was high, for reasons that required no explanation. She reviewed his chart, saw the previous admission and AMA discharge, and approached the conversation with the knowledge that whatever she offered needed to be both real and immediate if it was going to matter. She had learned, through experience with this population, that abstractions failed and timelines killed. A bed available in 9 days was, functionally, no bed at all. She located a detox bed with same-day availability at a facility in Germantown. She located a residential treatment program with an opening in 4 days. She documented both options, confirmed both with the facilities by phone, and presented them to Marcus in terms that acknowledged rather than ignored his fear of withdrawal. He remained in the hospital for 18 hours after regaining consciousness. During that time, he received IV antibiotics, wound care, buprenorphine for withdrawal management, nutritional support, and, critically, a conversation with the orthopedic team about the surgical options facing his arm. The surgeon was direct without being brutal. The bone infection had progressed to a degree that required surgical debridement at minimum. The wound's soft tissue involvement was extensive enough that reconstruction after debridement would be complex. The long-term prognosis for the arm's function, if treatment continued to be delayed, was poor. Marcus listened. He asked questions. The nurses documented that he appeared to understand what was being told to him. On the morning of the second day, a Wednesday, he was gone. The AMA form was signed at 6:47 a.m. before the day shift arrived, before the social worker was in the building, before the orthopedic team made morning rounds. A nurse noted the departure in the electronic health record with the clinical timestamp and a brief note. Patient left AMA. Risks discussed. Follow-up referrals provided. Staff unable to dissuade. Unable to dissuade. 3 words that contained an entire argument about what the healthcare system could and could not do. What individual choice meant in the context of physiological compulsion, and what accountability looked like when the options available were inadequate to the crisis they were meant to address. The hospital had done everything correctly. Every protocol had been followed. Every consult had been called. Every offer had been made. The chart was clean. The liability was documented, and Marcus was back on Kensington Avenue before the breakfast trays were distributed. Clinically, his case was classified as a treated and discharged overdose. The hospital's metrics captured 1 overdose, 1 response, 1 discharge. The bone infection, progressing hourly in his arm, didn't appear in that metric. The 4 a.m. phone call to a harm reduction line that he made from a borrowed phone 2 days later, saying he was thinking about going back in and then hanging up before anything was arranged. That didn't appear either. The metric said success. The arm said otherwise. And somewhere in Marcus's chest, in the place where people store knowledge too heavy to carry consciously. He understood that the next time he ended up in that hospital, the conversation about his arm would be different, more definitive, shorter, the kind of conversation where the surgeon stops using the word debridement and starts using a word with fewer syllables and more permanence. He just needed a little more time first. Everyone in his situation needed just a little more time. The infection did not need time. It was already running ahead of him. 6 days after leaving Temple University Hospital against medical advice, Marcus was back. Not by ambulance this time. He walked in through the emergency department entrance on Broad Street, which said something about the particular stubbornness required to walk anywhere with what his left arm had become by February 10th, 2025. The triage nurse who assessed him documented his chief complaint as arm pain, the first time Marcus had used the word pain in connection with the wound since it appeared. The xylozine's anaesthetic effect on the damaged tissue had, until now, kept the nerve signals suppressed below the threshold of conscious suffering. That it was now breaking through meant one of two things. Either the nerve damage had reached a point where the suppression mechanism itself was failing, or the infection had spread into tissue that still had functional sensation. Either explanation pointed in the same direction, upward, toward the elbow, toward the shoulder. The emergency physician who saw him recognized him from the previous admission, not personally, but through the chart that populated on the screen when his information was entered. 3 Temple admissions now. The wound documentation from each one created a visual timeline that required no medical training to interpret. A progression so consistent and so relentless that it looked almost algorithmic. Blood was drawn immediately. The results came back within the hour and produced the specific cluster of numbers that infectious disease physicians recognize as a body fighting a losing battle. White blood cell count at 24,000, nearly double the upper limit of normal, indicating massive active infection. C-reactive protein, a marker of systemic inflammation, elevated to a level associated with severe sepsis. Lactate, a chemical produced when cells are starved of oxygen and switch to emergency metabolic processes, elevated at 3.8 millimoles per litre. The lactate number was the one that changed the room's energy. Above 2 is concerning. Above 4 is associated with septic shock mortality rates above 40%. Marcus was approaching that threshold. He was septic, not locally infected. Systemically septic. Bacteria from the wound had breached the barriers of local tissue and lymphatic containment and entered the bloodstream, circulating through his heart, his lungs, his kidneys, his brain. Every organ in his body was now downstream of a bacterial load that his immune system, already compromised by years of malnutrition and chronic drug use, could not clear without aggressive intervention. The orthopedic attending was paged. The infectious disease attending was paged. The vascular surgery team was consulted. Marcus was moved from the emergency department to a monitored bed in less than 40 minutes, a speed that reflected not institutional efficiency, but clinical urgency recognized by everyone who had reviewed his numbers. The imaging told the rest of the story with the indifferent clarity of technology. An MRI of the left forearm and elbow, completed within 3 hours of admission, showed osteomyelitis extending from the mid-forearm through the distal ulna and radius, with involvement of the elbow joint itself. The joint space was compromised. The infection had crossed the anatomical boundary that, in the previous admission, had still separated the wound from the elbow's structural mechanics. Additionally, and this was the finding that the orthopedic attending presented to the assembled team with the particular gravity reserved for information that closes options, there was evidence of vascular thrombosis. The major vessels supplying the forearm had developed clots, a consequence of the chronic xylazine-induced vasoconstriction combined with the inflammatory response to infection. The forearm's blood supply was critically compromised independently of the infection. The tissue was dying from two simultaneous processes, each accelerating the other. The surgical team's assessment was not a long discussion. The evidence was unambiguous. The forearm was not salvageable. Attempting to treat with further antibiotics and debridement would extend Marcus's hospitalization, subject him to multiple surgeries with poor probability of success, and maintain a source of systemic bacterial seeding that was currently threatening his life. The infection would reach his heart valves or his brain before any reconstructive approach could work. The recommendation was below elbow amputation, removal of the forearm at a point above the most proximal extent of the documented infection, which the MRI placed approximately 8 centimeters below the elbow joint. Marcus was told directly, in the careful language of surgeons who have delivered this kind of news before. The social worker was present. A patient advocate was present. His comprehension was assessed carefully given his current clinical state and the ongoing buprenorphine administration for withdrawal management. The team documented that he demonstrated understanding of the procedure, its necessity, and the alternative, which was not keeping his arm but dying with it attached, probably within days. He consented. The surgery was scheduled for the following morning to allow the overnight antibiotic loading to begin reducing the systemic bacterial burden before the procedure. Amputations performed in the context of active sepsis carry higher complication rates. The inflammatory state affects healing, anesthesia management is more complex, and the cardiovascular system, already stressed by sepsis, responds unpredictably to surgical stress. The overnight preparation was not a delay. It was the difference between a survivable procedure and one that might kill him on the table. Marcus spent that night in a monitored bed, receiving IV vancomycin and piperacillin tazobactam, a combination covering the MRSA and gram-negative organisms his previous cultures had grown, along with IV fluids, buprenorphine, and the particular silence of someone who's been told something irreversible and is in the process of absorbing it. The surgery took 2 hours and 14 minutes. The orthopedic surgeon and the vascular surgery team operated together, the orthopedic surgeon performing the amputation through the mid-forearm at a level confirmed by intraoperative frozen section, to be clear of viable infected bone, the vascular team managing the vessels to ensure the residual limb would have adequate blood supply for healing. The wound was left partially open, a standard approach in amputation for infection, allowing drainage and reducing the risk of trapping bacteria under a closed surgical wound. It would be closed in a subsequent procedure once the infection was confirmed cleared. Marcus woke up in the post-anesthesia care unit with his left arm ending just below the elbow. The nursing notes from the immediate post-operative period describe him as oriented, calm, following commands. Calm is a word that appears in clinical documentation because it is observable and documentable. What it contained, in this instance, was not something a nursing note could capture. The particular stillness of a person who has just crossed a threshold from which there is no return, and who is not yet ready to feel the full weight of what lies on the other side. The phantom pain began within hours. This was expected. The nervous system, wired for decades to receive signals from a forearm that no longer existed, continued generating those signals into the void. The brain interpreted the input as real sensation from real tissue, burning, cramping, pressure, movement. Phantom limb pain following amputation is experienced by 60 to 80% of patients and can persist for years. It is managed with a combination of nerve blocks, medications, and mirror therapy, a technique in which visual feedback is used to retrain the brain's body map. In a hospital setting with adequate pain management resources, it is treatable. In the context of active opioid use disorder and ongoing withdrawal, it added a neurological torment to the physiological one already running. The withdrawal was the development that the nursing staff watched most closely in the 72 hours following surgery. Buprenorphine, administered during the admission, managed the opioid withdrawal component with reasonable effectiveness. The xylazine withdrawal component remained what it had always been, undertreated, partially managed with clonidine and benzodiazepines, productive of an agitation and autonomic instability that the surgical team had not fully anticipated in the post-operative setting. On the second post-operative day, Marcus's blood pressure spiked to 178/104, dangerous in any post-surgical patient, particularly one whose cardiovascular system had been stressed by sepsis and general anesthesia. The medical team adjusted medications, the numbers came down, the agitation continued. By the third post-operative day, the infectious disease team was cautiously optimistic about the systemic infection. Blood cultures drawn post-operatively were showing no growth, a preliminary sign that removing the source had reduced the bacterial load in the bloodstream. The wound was draining appropriately. The residual limb showed no signs of wound dehiscence or extending infection. By every surgical metric, the operation had been successful. The social worker visited twice daily. She had identified a residential treatment program in West Philadelphia with a bed available in 7 days, closer than anything previously located. She had contacted a case manager at the program directly, explained the circumstances, advocated for priority placement. The case manager had agreed. 7 days. Marcus told her he wanted to go. She documented it. Patient verbalized desire to engage with residential treatment. Specific program discussed. Intake date confirmed. She believed him. Not naively. She had enough experience to know that wanting and doing were separated in this population by a gap that could swallow the most genuine intention. But she believed that in that moment, in that bed, missing a forearm and 3 days post-sepsis, Marcus meant what he said. The question was never about intention. It had never been about intention. It was about the 168 hours between that hospital bed and the treatment program intake. The 7 days during which the drug's demand on his body would not pause, the withdrawal would not pause, and the street would remain exactly where it had always been, offering the only relief that worked immediately, completely, and without a 7-day waiting period. 7 days. The number sat in the room like a loaded question. Marcus was discharged on February 17th, 2025, 7 days after the amputation. The discharge paperwork was thorough. 4 pages of wound care instructions for the residual limb, medication reconciliation listing the buprenorphine prescription, a follow-up appointment with the orthopedic clinic in 10 days, a referral to the prosthetist, and a single phone number for the residential treatment program in West Philadelphia, where a bed was confirmed available starting February 24th, 7 days away. The social worker had done everything a social worker could do within the structure available to her. Marcus left the hospital with a 2-week buprenorphine prescription, a bus pass, a wound care kit for the residual limb, and approximately $40 in his pocket from a patient emergency fund the hospital social work department maintained for exactly these transitions. He had no phone. His had been lost or stolen sometime in January. He had no housing. He had one arm, and he had 7 days to fill before the treatment program would open its door. The first 24 hours went better than the statistical probability suggested they should. He made contact with a harm reduction outreach worker he knew, explained his situation, and was connected to a transitional housing unit in Frankfurt. Not a shelter requiring sobriety, but a low-barrier facility that accepted people in active addiction and provided a bed, a roof, and 2 meals a day. He got a bed. He took the buprenorphine as prescribed. The residual limb hurt with a complexity that encompassed both the physical reality of the surgical wound and the phantom fire of a nervous system still searching for what wasn't there. The buprenorphine managed the opioid withdrawal incompletely. It was designed to. Buprenorphine is a partial opioid agonist. It occupies opioid receptors and reduces withdrawal severity without producing the full effect of drugs like fentanyl or heroin. For most people on a stable, adequate dose, it works well. Marcus had been started on a dose calibrated for hospital conditions, where his withdrawal could be monitored and adjusted. The dose in his discharge prescription was the same dose, but the conditions were not the same. The xylazine withdrawal component, inadequately addressed in the hospital, essentially unaddressed on discharge, produced an agitation and physical restlessness that buprenorphine did not touch. By the second day, he was sleeping 2 hours a night. Sleep deprivation in the context of opioid withdrawal is not merely uncomfortable. It is destabilizing in a way that directly undermines every cognitive and emotional resource required to maintain the intention to stay clean. The prefrontal cortex, the brain region responsible for planning, impulse control, and long-term decision-making, is acutely sensitive to sleep deprivation. 2 days of severely disrupted sleep produces cognitive impairment measurable on neuropsychological testing. 5 days produces impairment comparable to moderate intoxication. Marcus was operating on compromised sleep while simultaneously managing withdrawal, phantom limb pain, the psychological processing of a permanent physical change, and the knowledge that one phone call to someone he knew on Kensington Avenue would make all of it stop immediately. He lasted 4 days in the transitional housing. On the morning of February 21st, 3 days before the treatment program intake, he was gone. The facility's records noted he left voluntarily at approximately 7 a.m. No forwarding information. No reason documented because no one was there to document it. The overnight staff had ended their shift. The day staff hadn't arrived. And the particular hour of 7 a.m. in a low-barrier housing facility was a window of institutional inattention that people who needed to leave without discussion had learned to use. The research on this specific failure point, the discharge to relapse pipeline, is extensive and damning in equal measure. A 2024 study published in JAMA Psychiatry, analysing outcomes for 1,847 patients discharged from Philadelphia hospitals following opioid-related admissions, found that 67% had used within 72 hours of discharge. For patients discharged with a gap of more than 5 days before treatment entry, the relapse rate within that gap period was 84%. The single most predictive factor for successful transition to treatment was same-day or next-day intake, not the quality of the treatment program, not the patient's motivation level, not the medication prescribed on discharge. The gap was the killer. A same-day intake bed for Marcus did not exist. Not because no one tried to find one, because there weren't enough beds in the entire city to provide same-day intake for the volume of people discharged from Philadelphia hospitals following drug-related admissions. The math was simple and catastrophic. Approximately 47 addiction treatment facilities operated in Philadelphia in 2025, with a combined residential capacity of roughly 1,200 beds. The city's estimated active opioid use population was between 70,000 and 90,000 people. The ratio required no statistical training to interpret. Marcus was back in Kensington by noon on February 21st. He injected within 30 minutes of arriving. The withdrawal stopped. The phantom pain, which the fentanyl-xylazine combination suppressed through a combination of opioid analgesia and xylazine sedation, reduced to a background noise rather than a foreground scream. The accumulated 4 days of sleeplessness resolved into the heavy, pressing sedation that xylazine delivered. He slept for 6 hours in a doorway on Tusculum Street, his residual limb resting across his chest, the surgical wound covered by the hospital's dressing, which was already beginning to need changing. The practical reality of injecting with one arm is not something that most people consider until confronted with it. Marcus's right hand was now the only hand he had. Injection with one hand, finding a vein, inserting a needle, managing the process without the second hand that the procedure normally requires, demanded a level of manual dexterity and adaptation that people in Kensington had developed specific techniques for. Others helped. Equipment was improvised. The community's accumulated knowledge of how to use under every variety of physical constraint was applied without ceremony, because ceremony was a luxury and the withdrawal was not. The new injection sites were in his right arm. The xylazine was already at work on the microvasculature. The treatment program intake date of February 24th passed. Marcus didn't make the call. He didn't have a phone to make the call with, and by February 24th the calculation had shifted. He was using, the withdrawal terror had been reset, and the program required a 5-day medically supervised detox before residential entry, which meant 5 days of withdrawal before any relief, which meant the offer on the table was suffering now for the possibility of something better in a week. The brain in active addiction does not make intertemporal trade-offs efficiently. This is not a character defect. It is a documented consequence of what opioids and xylazine do to the prefrontal cortex's reward processing circuitry. The treatment bed sat empty for 4 days before the facility offered it to the next person on the waiting list. Somewhere in Philadelphia, the person who'd been waiting behind Marcus on that list got their intake call. This is how the system worked. Not as a coherent treatment infrastructure, but as a lottery in which available slots cycled through a waiting population, and the timing of availability relative to the timing of individual readiness was largely a matter of chance. Marcus's chance had been February 24th. The next chance, the next available bed, the next window of institutional capacity aligning with his location in the city, was a date that didn't exist yet on any calendar. March arrived. Marcus's right arm developed a dark spot at the crook of the elbow, small, slightly sunken, familiar to anyone who had watched his left arm over the preceding 3 years. The wound care nurse at Prevention Point photographed it on March 8th during an outreach visit and added it to the database. She dressed the residual limb wound, which was healing slowly but adequately given that Marcus was no longer injecting into it. She documented the new right elbow lesion with the clinical precision of someone who had seen this trajectory enough times to know its destination. She scheduled him for a follow-up visit the following week. He came back on March 15th. The right elbow wound had grown, not explosively, not the way a wound grows when infection takes hold systemically, but steadily, the way xylazine wounds always grew when the drug continued and the blood supply continued to fail. The nurse dressed it, photographed it, updated the database. She asked Marcus if he was still thinking about treatment. He said yes. She asked if he wanted her to make calls on his behalf. He said yes. She made 3 calls that afternoon, working her way through a contact list of MAP providers and residential programs. 2 had waiting lists exceeding 3 weeks. 1 had an intake appointment available in 11 days. She scheduled it, wrote the date and address on a piece of paper, and gave it to Marcus along with the wound care supplies and the naloxone kit that she provided at every visit without comment, because providing it without comment was the difference between someone having it and someone not having it. 11 days, the same arithmetic, the same gap, the same probability distribution that the JAMA study had already calculated. Marcus folded the paper and put it in his jacket pocket. He had one arm with a healing surgical wound where the forearm used to be, and another arm with a growing necrotic lesion at the injection site, and a piece of paper with an address on it, that represented the distance between where he was and where the system was capable of bringing him. 11 days was not a long time. For most purposes, in most lives, 11 days was nothing, a gap between vacation and return between one weekend and the next. In Kensington, 11 days was a unit of measurement with a specific and well-documented mortality rate attached to it. The paper stayed in his pocket. Whether it would stay in his pocket for 11 days was a question that the statistics answered one way, and the human capacity for will and accident answered in ways that statistics could never fully predict. Both answers were running simultaneously. The clock didn't care which one arrived first. Pull back far enough from Kensington Avenue and the picture changes, not in the way that distance usually softens things, making the difficult look manageable, the catastrophic look contained. In this case, distance reveals a scale that the street-level view actually understates. From above, from the perspective of data and policy, and the institutions responsible for managing what Philadelphia had become, the crisis looked worse than any individual story could convey. Because individual stories have faces and names, and a human capacity to generate empathy. Numbers don't. And the numbers in 2026 Philadelphia were staggering. By January 2026, the Philadelphia Medical Examiner's Office was projecting an annual overdose death toll that would exceed 1,400 people, surpassing every previous record in the city's history, surpassing the previous record set in 2023, which had surpassed the record set in 2021. The trajectory was not a spike, it was a slope, climbing at a consistent angle year over year, with no inflection point visible in the data. Each year's record became the floor from which the next year's record was measured. For context, 1,400 overdose deaths in a city of 1.5 million people is a mortality rate that exceeds the peak annual death toll from HIV/AIDS in New York City during the worst years of that epidemic, adjusted for population. Philadelphia's overdose crisis had, by standard epidemiological metrics, surpassed the scale of every urban drug catastrophe in American history. This comparison appeared in peer-reviewed literature in 2024. It produced no emergency declaration from the federal government equivalent to the HIV response. No Ryan White Act for Tranq. No ACT-UPPY movement that commanded national attention and congressional action. Kensington remained, in the national political consciousness, a local problem. The political landscape in Philadelphia in 2026 was a map of exhaustion and entrenchment. Mayor Cherelle Parker, who had taken office in January 2024, inheriting a crisis already beyond containment, had pursued a strategy that combined visible enforcement with rhetorical commitment to treatment, a combination that satisfied the political requirement to appear active without resolving the structural contradictions that made the crisis self-sustaining. The Kensington Corridor Initiative, launched in spring 2024, deployed additional police, sanitation crews, and outreach workers simultaneously, an acknowledgement that enforcement alone had failed, paired with a resource allocation that remained inadequate for the treatment component to compensate. Sweeps happened, people moved, the encampments reformed, the overdose rate continued its ascent. The supervised consumption site battle had reached, by 2026, a state of legal and political stasis that functioned as a permanent veto on evidence-based intervention. The organization's Safe House had been fighting in federal court since 2019 to open a supervised consumption site in Philadelphia. The legal argument that the Controlled Substances Act's crack house provision did not apply to a facility operating openly with public health intent had produced a circuit split, a Supreme Court petition, and years of litigation during which the facility never opened and thousands of people died at injection sites that were unsupervised unmonitored and unreachable by immediate overdose response. The Supreme Court declined to hear the case in 2024, leaving the lower court ruling in place and the facility legally blocked. Every year the legal battle continued was a year in which the intervention most likely to prevent on-site overdose deaths remained unavailable in the city most in need of it. Other countries had watched this legal argument with the particular bewilderment reserved for American drug policy. Vancouver's Insight had been operating since 2003. More than 2 decades of evidence accumulation that the facility's opponents in Philadelphia could not engage with honestly, because honest engagement would have required acknowledging that the evidence was decisive. Over 23 years, Insight had supervised more than 3.6 million injections, 0 on-site overdose deaths. A peer-reviewed study published in The Lancet in 2011 documented a 35% reduction in overdose mortality in the surrounding neighbourhood following the site's opening. Studies in Amsterdam, Sydney, Geneva, and a dozen other cities replicated the findings with sufficient consistency that the evidence base was, by any scientific standard, settled. Portugal offered a different but equally instructive model. The country's 2001 decriminalisation of all drug possession, redirecting resources from prosecution to treatment and harm reduction, had produced outcomes so positive that Portuguese public health officials had spent 2 decades presenting them at international conferences, while American legislators declined to draw conclusions. Drug-related HIV infections in Portugal dropped by more than 95% between 2000 and 2020. Drug-related deaths fell to among the lowest rates in the European Union. The population in treatment doubled. None of this happened because Portuguese people were different from American people. It happened because the policy framework was different, treating addiction as a health condition rather than a criminal one changed every downstream outcome. Philadelphia couldn't replicate Lisbon, not because the evidence was unclear, because the political cost of being seen to endorse what opponents would characterize as enabling drug use exceeded, for most elected officials, the political benefit of preventing deaths in a population that voted at low rates and generated significant public discomfort. The national media's relationship with Kensington had evolved into something that public health professionals described with barely concealed frustration as disaster tourism with better camera equipment. Vice, NBC, the New York Times, the BBC, NHK, Der Spiegel, every major media organization in the developed world had filed at least one Kensington documentary or feature by 2026. The footage was consistent. The avenue, the zombified figures sedated mid-stride, the wounds, the encampments, the devastation compressed into visuals that were simultaneously accurate and deeply misleading. Accurate because what the cameras captured was real. Misleading because the framing, the aesthetic of ruin, the implicit narrative of individual degradation consistently displaced the structural story with the spectacle story. Viewers came away understanding that something terrible was happening to people in Philadelphia. They came away with significantly less understanding of the prescription economics, the cartel supply chains, the Medicaid gaps, the treatment bed ratios, and the 40 years of policy choices that had assembled the spectacle the camera was capturing. TikTok had added a dimension that previous media cycles hadn't included: real-time first-person footage uploaded by people on the strip itself, by passers-by filming through car windows, by journalists, and by people who simply had phones and found the footage compelling. The Kensington hashtag on TikTok had accumulated more than 2 billion views by early 2026, a number that exceeded the viewership of most primetime network television events. The comment sections were a reliable cross-section of public opinion: grief, horror, rage at the users, rage at the politicians, dark humour, genuine calls for help, and a significant contingent of people apparently watching for entertainment. Among the harm reduction workers who spent their days on the strip, the media saturation had produced a specific and understandable resentment. Every documentary crew that arrived needed access, needed introductions, needed someone to explain the context. Every documentary that aired generated a brief cycle of public attention, a flurry of donations to the organizations featured, and then nothing. No sustained policy change, no emergency resource allocation, no structural intervention. The attention was real. The impact was not. Meanwhile, the numbers kept moving. The 2025 Philadelphia Overdose Report, published by the Department of Public Health in January 2026, contained a statistical detail that circulated briefly through public health social media before disappearing from broader discourse. The average age of overdose death in Philadelphia had dropped from 43 in 2019 to 38 in 2025. 6 years, 5 years shaved from the average age of death. The crisis was not only killing more people, it was reaching them younger, moving faster through the population, compressing the timeline from first use to fatal outcome in ways that the transition from fentanyl to fentanyl xylazine had directly accelerated. New users in 2025 and 2026 were developing Tranq wounds in months that previously had taken years to develop. The wound burden was appearing in people who had been using for 6 months. Cases that the harm reduction community had previously characterized as the outcome of long-term, severe addiction were now appearing in people barely past the beginning of their trajectory. The drug had gotten more efficient at destroying people, and the population encountering it was not shrinking. In state government, Pennsylvania's legislature had passed a package of addiction funding measures in 2024 that increased treatment bed capacity by approximately 200 statewide, a number that harm reduction advocates received with the bleak humour of people who had done the math. 200 beds for a state with an estimated 300,000 people in active opioid use disorder. The legislation was described in press releases as a significant investment in combating the opioid crisis. The press releases were accurate about the investment existing and silent about the ratio. The federal government's primary response to the xylazine crisis in 2025 had been the Xylazine Action Plan, a multi-agency document outlining research priorities, regulatory responses, and coordination mechanisms between the DEA, FDA, SAMHSA, and NIH. The document ran to 47 pages. It funded research into xylazine reversal agents, improved toxicology screening, and enhanced surveillance. It did not fund emergency wound care infrastructure. It did not fund same-day treatment access. It did not fund the harm reduction organizations performing daily triage on a population that the formal healthcare system couldn't reach. Research funding and emergency response are not the same thing. In a crisis measured in days and hours and the gap between a discharge and a treatment intake, a 47-page coordination document was a map handed to someone drowning. What the outside view ultimately revealed, the view from data, from policy, from international comparison, from the aggregate of everything documented and published and debated, was a city that had become the site of a public health catastrophe of historic scale, surrounded by a political and institutional apparatus that understood the catastrophe well enough to describe it in detail and lacked either the will or the structural capacity to interrupt it. The people inside that catastrophe, the 70,000 estimated active opioid users in Philadelphia, the harm reduction workers, the emergency physicians, the paramedics running the same calls night after night, did not need the outside view to understand this. They were living the conclusion that the outside view could only observe. Marcus was one of 70,000 reasons the outside view kept failing to matter enough. March 26th, 2026. Prevention Point's mobile wound care unit was parked on the corner of Kensington and Cambria, which was not its scheduled location for that Thursday, but had become the de facto stop because the population density at Cambria had increased following the latest sweep of the Gurney Street encampment. The nurse running the unit that morning had been doing this work for 6 years. She had the particular composure of someone who has processed enough suffering to stop being surprised by it without having stopped caring about it, a psychological position that requires constant maintenance and occasionally fails without warning. Marcus showed up at 9:47 a.m. She recognised him immediately, not just from the records but from the residual limb, which was visible below the shortened left sleeve of his jacket, and which had become, in the harm reduction community's informal network of shared knowledge, a kind of landmark. People knew Marcus. People knew what had happened to his arm. His continued presence on the strip was, to some, a testament to the human body's capacity for survival under conditions that should have ended it. To others, it was simply the latest chapter in a story they had watched too many times. The wound on his right arm had progressed in the 2 weeks since the previous documented visit. The lesion at the inner elbow, first photographed on March 8th at approximately 1.5 centimetres, had expanded to nearly 4 centimetres, with central necrosis already visible. The same dark, sunken centre that his left arm had displayed at the equivalent stage 3 years earlier. The trajectory was identical. The timeline was faster. His body, depleted by years of malnutrition and chronic infection, and the surgical trauma of the amputation, was less capable of mounting even the partial resistance it had managed the first time. The nurse cleaned the wound without comment, because comment at this stage added nothing, and removed the clinical focus required to do the job properly. She debrided the necrotic margin with sterile scissors, removing the dead tissue that bordered the viable wound edge, a process that sounds dramatic but was, in practice, performed with the quiet efficiency of someone who had done it hundreds of times. She irrigated the wound, applied an antimicrobial dressing, and photographed it from 3 angles for the database that now contained 22 separate entries for Marcus across 3 years. Then she asked him the question she asked every client at every visit, whether they were thinking about treatment. Marcus said yes. This time, and the nurse's documentation reflects this with a specificity that suggests she recognised something different about the answer. He didn't say it in the generalised future tense way that people often said yes to maintain the relationship with a care provider without committing to action. He said he was ready. He gave a specific reason. His daughter Destiny had turned 9 the previous week. He had learned about it from his ex-girlfriend's sister, who had relayed the information through the informal network of people who still knew him from his previous life. He hadn't seen Destiny in over a year. The birthday was a data point that had apparently crossed some internal threshold. The nurse did not analyse the significance of this. She acted on it. She made calls from the mobile unit's phone while Marcus sat on the van step with his wound freshly dressed and a cup of coffee someone had brought. 3 calls. The first 2 yielded waiting lists. 3 weeks, 2 weeks. The third reached a medication-assisted treatment intake coordinator at a clinic in Hunting Park, 4 miles away, who had a cancellation opening for the following morning at 8 a.m. Not residential treatment, outpatient MAT, a daily buprenorphine program with counselling components. Less intensive than residential, but immediate. Same-day registration possible. The intake appointment was tomorrow. The nurse wrote the address, the time, and the coordinator's name on a card. She added the Prevention Point outreach worker's direct number. She told Marcus she would have someone meet him at the clinic entrance at 7:45 a.m. to make sure he found it. She scheduled a wound care follow-up for April 2nd. Marcus took the card. He looked at it for a moment in the way that people look at things they're trying to memorize because they don't trust their ability to hold on to the physical object. Then he put it in his jacket's inner pocket, against his chest, where it was less likely to fall out. He thanked her. She told him she'd see him tomorrow morning. She watched him walk north on Kensington Avenue, his left sleeve pinned up below the elbow, his right arm bent slightly at the side in the posture that people develop to protect a wound they're aware of. He was 35 years old. He walked like someone older, with a careful, energy-conserving gait of a body that had learned to spend its reserves cautiously. He turned a corner and was gone from her line of sight. She documented the visit, the wound measurements, the appointment scheduled, the follow-up date. She moved to the next client. The outreach worker who was supposed to meet Marcus at the clinic entrance at 7:45 a.m. on March 27th arrived at 7:42 and waited until 8:30. Marcus did not appear. The intake coordinator held the slot until 8:15, and then, per protocol, offered it to the next person on the cancellation list. The slot was filled within 20 minutes, because it was always filled within 20 minutes, because the demand never paused, because for every person who missed an appointment, there were a dozen people who would have taken it. The outreach worker called the prevention point line and reported the no-show. It was documented. For 3 days, no one in the harm reduction network had a confirmed sighting of Marcus. This was not unprecedented. People moved, stayed inside, avoided the strip for various reasons. The absence was noted but not yet alarming. On March 29th, an outreach worker doing a welfare check on an abandoned row house on Gurney Street, one of the buildings that had been the centre of the encampment before the last sweep, found him on the second floor. He had been dead for an estimated 36 to 48 hours. The medical examiner's office placed time of death at approximately March 27th, the morning of the missed intake appointment, though the margin of error given the conditions made precision impossible. He was found on his back, which suggested the xylazine sedation had taken hold before he could move to a position that would have protected his airway. The fentanyl-xylazine combination had produced the respiratory depression it always produced, and this time there had been no one close enough to notice, no woman awake with withdrawal cramps watching his chest, no phone call made at the critical window. The medical examiner's report listed cause of death as acute fentanyl/xylazine toxicity. Manner of death: accident. He was 35 years old. In the Philadelphia Department of Public Health's overdose surveillance system, Marcus became case number 847 in the 2026 dataset, the 847th overdose death recorded in the city since January 1st. The date was April 2nd, when the ME's report was formally filed, though his death had occurred days earlier. April 2nd was also the date the prevention point nurse had scheduled his wound care follow-up. She learned about his death through the Harm Reduction Network's informal communication system, the same network that had tracked him, referred him, dressed his wounds, and scheduled the intake appointment he never made. The information reached her as a text message from a colleague who had heard from the outreach worker who had found him. 3 degrees of separation, a chain of people who had all known Marcus, and who were all, in their various ways, absorbing another entry in a ledger that never stopped accumulating. She added a final entry to his wound care record. Deceased. Date of last contact March 26, 2026. Then she moved to the next client. Because the van was still parked on Kensington and Cambria, and there were 12 people waiting, and stopping was not something the situation permitted. Destiny Reyes, 9 years old, living in northeast Philadelphia with her mother, did not know her father was dead for several weeks. The notification process for next of kin in overdose deaths involving unhoused individuals without current address documentation is slow and dependent on information chains that are often incomplete. When she was told, by her mother, in a way that tried to be honest without being brutal, which is one of the hardest things a parent is ever asked to do, She did not have a framework for processing it that 9 years had given her time to build. She had a photograph from the Please Touch Museum from when she was 4 that she kept in a shoebox under her bed. The man in the photograph looked nothing like the man her father had become. Both were real. That was the part no one had adequate language for. 847 is a number. It appears in a table in a public health report alongside 846 other numbers, each representing a person whose life compressed under the specific pressure of addiction and poverty and institutional failure into a data point. The report was published in May 2026, cited in 3 newspaper articles, referenced in 1 city council hearing, and added to a bibliography of evidence that continued to grow while the conditions it documented continued unchanged. Marcus had wanted to stop. The nurse had believed him, and she had been right to believe him. The wanting was real. What the wanting ran into was not weakness or character failure, or the moral deficit that the dominant cultural narrative assigned to people in his position. It ran into a gap. 11 days, 7 days. The distance between a hospital discharge and a treatment bed. The distance between a van parked on Kensington Avenue and a clinic 4 miles away on a morning when the body's demand and the spirit's intention arrived at a crossroads and the body won, as it usually wins, because the body has chemistry on its side and chemistry doesn't negotiate with intention. The gap killed Marcus Reyes. The gap, and everything that built the gap, the prescription that started the dependency, the insurance structure that cut off legitimate treatment, the street supply that filled the void, the cartel economics that added xylazine to the mix, the DEA's scheduling delay, the treatment bed shortage, the discharge protocols that sent people into the street with a phone number and a bus pass and called it an adequate handoff. He was not the first. He was not the last. He was number 847, and the year was not over, and the conditions that produced him were intact. And on Kensington Avenue the corner dealers were at their corners, and the harm reduction workers were at their van, and the wounded were waiting for wound care, and the gap between what existed and what was needed remained exactly as wide as it had been when Marcus Reyes was a construction worker in Bucks County, who filled a legal prescription for a herniated disc and trusted that the system had considered the consequences. It hadn't. Number 848 was already out there somewhere. So was 849. The surveillance system would find them eventually, when the ME's reports came through, when the toxicology confirmed what everyone already knew. The dataset would grow. The reports would be published. The citations would accumulate. And on Kensington Avenue, the mobile wound care unit would park on the corner of Kensington and Cambria, and the nurse would open the van's side door, and the line would form, and the work of bearing witness to a preventable catastrophe would continue, because someone had to do it, and because the alternative, stopping, looking away, deciding that the numbers had become too large to mean anything, was the one failure that the people doing this work refused to commit. Destiny Reyes kept the photograph in the shoebox. The man in it was smiling, holding a 4-year-old girl up towards something out of frame. A dinosaur skeleton, a space capsule, something that had seemed worth reaching for. His arms were whole. His face was his own. He looked like someone who expected to be there tomorrow,